Hello, this is Mike, and we're going to attempt to do a overview of this PowerPoint to take the place of the face-to-face lecture while I can't be there. This is going to be the respiratory lecture. I'll try to move through. We have about 75 slides. I'll try to move through them, but I will try to interject where I think there should be some additional input. I encourage you to please read this chapter in your book and review. Unfortunately, a lot of times anatomy and physiology is general memorization. So I know it can be difficult. So anyway, let's move along. The respiratory system consists of tubes that filter, warm, and moisturize incoming air, and they transport it into the microscopic alveoli where the gases are exchanged, and this occurs deep within the lungs. The entire process of exchanging the gases between the atmosphere and the body cells is called respiration. So the entire process of this exchange, the total overview, is called respiration. Now, respiration consists of ventilation, which is the gas exchange between the blood and the lungs. We call that external respiration. And then we have gas transport in the bloodstream, or the gas exchange between the blood and the body cells, and that's internal. So, general overview, respiration, breathing. Within that, we have ventilation, gas exchange between the blood and the lungs as the blood filters through the lungs, and we have the exchange taking place there. And then the next exchange will be actually in the bloodstream as the blood transports the oxygen to the individual cells throughout the whole body. We're going to call that internal or cellular respiration. So the organs of the body system, there are two organs of the respiratory tract that can be divided into two subgroups. You have the upper respiratory tract, which is going to be your nose, nasal cavities, sinuses, and pharynx. And then you have the lower respiratory tract, which is going to consist of the larynx, trachea, bronchial tree, and the lungs. And here's a picture. I'm sure this is right from your book. You need to be familiar with this. You can see how one part of the respiratory system, the upper airways, nasal cavity, are all interconnected into the lower portion. So what affects one could affect the other because they're all interconnected. Your nose is supported by bone and cartilage, and this provides an entrance for the air for which you're going to breathe. And it's going to come in through your nose. And we all know we have hairs in our nose, we have mucus in our nose, and that's going to warm and filter the air that's coming into our body. That's going to be the first filtration system. So the air is going to come into the two holes, as you all have, and those are known as nostrils. Past the nostrils, we have the nasal cavity, which is a space posterior to the nose, and it's divided medially by the nasal septum. So it's going to come in behind the nasal cavity, and you're going to have a septum that separates the area of the nasal cavity. So behind the nares, nasal cavity separated by septum. Inside of the nasal cavity, you have nasal conchae, divided the cavity into passageways that are lined with mucous membranes. And these mucous membranes help to increase the surface area to allow that air that's coming into your body to be warmed and, like I said before, moisturized, and also continue to filter any particles out. Now, this is what's going to primarily sometimes get irritated when you have a lot of particles, and your body may reject some of the air coming in, and it'll cause you to sneeze. It's just one mechanism. Those particles are trapped in the mucus or carried to the pharynx by ciliary action. We've talked about that before, like the little brushing motion that occurs within the ciliary. That's moved to the back of your mouth. You eventually swallow it. It's carried to the stomach. Gastric juice eats up most of anything that's brought to it, and any microorganisms in the mucus. So that's primarily how we clean the air that we are breathing in. And again, a cross section showing you the conchae, the frontal sinuses, nostrils. This is all in your book. And you can see the path of how you would filter the air and how that would go down, and you would eventually end up swallowing that. This is basically one of the histology slides we looked at when we did lab of the brush-like cilia with the tissue. This also breaks down in a three-dimensional where it shows you the mucus and particles. So basically, this is just showing you how it filters out and moves it on down. We have the paranasal sinuses. These sinuses are air-filled spaces within the maxillary, frontal, ethmoid, and sphenoid bones of the skull. Now, all of these spaces are open to the nasal cavity and are lined with mucous membranes that is continuous with the same lining as before. The sinuses reduce the weight of the skull and serve as resonant chambers to affect the quality of voice. As you've all probably had a cold or known someone that's had a cold, if you have a head cold, your voice changes. So it's all about the air movement, this is why your voice changes, basically. And that your skull doesn't weigh like, an enormous amount of weight because it does have some air cavities within it. The pharynx is the common passageway for the air and food. Now, you need to remember that. And the pharynx aids in producing sounds for the speech. So that's also involved in speech. So, you've got your nasal cavities, your pharynx, and then there are 3 subdivisions to this pharynx. You're going to have the nasopharynx. Now remember, this is the passageway for air and food. They both come through the pharynx. The nasopharynx, the ornopharynx, and the laryngopharynx. And here is a model representation that you can kind of look at. Nasopharynx is going to be the upper. As we move down, we have the ornopharynx, and then on down deeper, the laryngopharynx. It's just all describing, you can see it labeled here. It's all describing the pathway of the air and food. The larynx is an enlargement in the airway superior or on top of the trachea, but it's below the pharynx. And it helps keep particles from entering the trachea, which could cause a lot of problems if we get food particles or any other particles into the lungs. And this is the area, the larynx, that houses your vocal cords. The larynx is composed of the framework of muscles and cartilage bound by elastic tissue. And this is the thyroid and cricoid cartilages, or hyaline membrane cartilages. And the epiglottis is elastic cartilage. And here's a representation of that. The cricoid cartilage, if you see between the cricoid and the thyroid, this area here is where we would do emergency airway procedures. If any of the upper airway was occluded, we could still access the airway down lower at the cricoid level. Inside the larynx are 2 pairs of folds of muscles and connective tissue covered with mucous membrane that make up the vocal cords. Now, the upper pair are called the false vocal cords. The lower pair are the true vocal cords, which is going to make your speech. Changing the tension on the vocal cords controls the pitch, while increasing the loudness depends on the force of air coming through your vocal cords, which is going to vibrate those vocal cords. So our pitch controlled by muscles, and loudness is going to be how much air or hot air, no pun intended, you're blowing out through those vocal cords. The pharynx, oral cavity, tongue, and lips transform the sound waves into words. So if any of those, your tongue can, I've had people that have had surgery to the tongue where maybe part of it has been removed, lips, oral cavity, any of these things will affect your speech in some way. During normal breathing, the vocal cords are relaxed and the glottis is a triangular slit. During swallowing, however, the false vocal cords and the epiglottis close off the glottis, because when you swallow food, these false vocal cords and epiglottis are going to protect that glottis, or going to protect the vocal cords, I should say, so you don't swallow food into your lungs, because that's called aspiration, and that could lead to a lot of complications. Now, I'm not saying it doesn't happen. Sometimes we eat too fast, our muscles don't contract quick enough, and we end up, usually if something just touches that area, you're going to cough. It's a reaction, and you cough it right out. But you could actually aspirate, we call that aspiration, into the lungs, which is not good. And here's a picture of the false vocal cords on the outside, the true vocal cords in here in the middle. These are what's going to be closed off. All these will close off when you swallow. Here's an actual picture, looks like from a bronchoscopy. And as you can see here, your false vocal cords here and your true vocal cords in this area here. And then this area right here is taking you down into your lungs, which is called your trachea. We don't want any food or foreign objects to get down in there if possible. Now the trachea is going to extend downward anterior to the esophagus. So the trachea sits on top of the esophagus. So they're right there beside each other. And they move into the thoracic cavity, which is going to be the chest area. The trachea is then going to split, and this is very important, into the right and left primary bronchi. And I'm sure there'll be a picture coming up to show you that. The inner wall of the trachea is lined with ciliated mucous membrane with many goblet cells. Now remember, goblet cells create mucus. And of course, the cilia is the brush-like things that move along particles that serve to trap incoming particles, as it says. The trachea wall, the wall surrounding it, is supported by 20 incomplete cartilaginous rings that keep the airway open. Now, these are cartilage rings, so they could be damaged or collapsed if you had trauma to the neck. You could actually collapse the tracheal wall, which would cause an airway obstruction because air could not move anymore. So just kind of keep that in mind. It's pretty sturdy, the cartilage that makes up the trachea, but it can be damaged. So keep that in mind. And again, here's a picture. And remember, when we're looking at the body, we're looking from the patient's view. So this is going to be the left, or the patient's left, and the right. And you can see the left mainstem bronchus and the right. Your cartilaginous cartilage rings are here, making up the trachea. In particular attention, do you notice how the right mainstem's a little bit straighter? That's when we actually put tubes down in here to put people on mechanical ventilators, or to suction, even driving a suction catheter down in here to try to get mucus out. It's real easy to slide right into that right mainstem because it's not on much of an angle, where you see the left actually is at more of an angle. So then we have the bronchial tree, and the bronchial tree consists of the branded mucous membrane lined tubes leading from the trachea to the alveoli. Now, the bronchial tree continues to warm, moisten, and filter incoming air. So, as you can see, as the air is moving in toward your lungs, it continues to be filtered and warmed to try to make it acceptable to your lungs. The bronchial tree begins with two main primary bronchi, each leading to a lung, and that's going to be the left and the right, which we showed you up here. Next are the lobar secondary bronchi, going to each lobe of the lung. Now, these branch into segmental or tertiary bronchi into each lobe segment. So basically, it's like a tree limb that keeps branching out and eventually gets very, very microscopically small. The segmental branch further subdivide into the terminal bronchioles, respiratory bronchioles, and then the alveolar ducts, and eventually ending up as alveolar sacs, which are microscopic, where actual ventilation occurs in that area, or respiration occurs in that area, and the CO2, carbon dioxide, and oxygen are exchanged. And they terminate into the alveoli. The alveoli, and I'm sure we'll see some pictures, or if you can see them under a microscope, are like little bunches of grapes, and they are all interconnected to each other, and I'm sure there'll be some pictures coming up. It is through the thin epithelial cells of the alveoli that the gas exchange between the blood and air occurs. So you have blood vessels running around the alveoli that are bringing blood to the alveoli and taking the blood away from the alveoli to supply the body with oxygen and nutrients from the air. And here is a picture, segments of the lung, your pleuris, which we've talked about before, parietal and pleural. Remember, the difference between visceral always lies against the organ parietal. Then you have a potential space here that if it gets filled with air or fluid, we have problems because it pushes the lung in. The alveoli, these little grape-like structures, and they are all interconnected. And actually, it doesn't show it here, but all of these are interconnected and interdependent on each other. This is a representation about how the blood vessels surround each alveoli. We're going to bring fresh oxygenated blood from the heart. And that's going to be disseminated to the body. That's going to be the oxygen enriched side here. Oxygen on this side is going to be deoxygenated blood coming around the alveoli. CO2 is going to be taken out of this and expelled as we exhale. So the lungs actually, the right and the left, they're soft, spongy. Actually, in our respiratory lab, we have some pig lungs, and you could actually play with them, but they're soft, spongy, kind of cone-shaped, and they're separated medially by the mediastinum in the middle, and are enclosed by the diaphragm and thoracic cage. So they don't come out of your chest. They're totally enclosed by the thoracic cage, and on the bottom of them, you're going to have the diaphragm, which is the huge muscle associated with breathing. The primary bronchus and large blood vessels that enter each lung in the medial surface. The primary bronchus and the large blood vessels enter each lung in the medial surface. A layer of serous membrane, the visceral pleura, is attached to the lung, which we just said, and the parietal pleura lines the thoracic cavity. Now, in between those two pleuras, as we discussed before, we have serous fluid. This helps to lubricate the pleural cavity between these two membranes, so when you breathe, it doesn't hurt, because it's kind of a lubricant, like a car lubricant, or WD-40, if you know what that is, in between, so the lungs can move. And this is a cross section. Looks like it's probably from the bottom up. It looks kind of like a CT scan, which also kind of gives you another view of where the heart lies, which would be here. Where the pleuras are, you can see the rib cage here, and you can see how you have the parietal pleura out against them, the visceral pleura, which is closer inside to the lung, and again, you have the fluid in there that keeps everything frictionless. As I said before, if air or fluid gets in here, this will actually impede into the lung and collapse it. If this gets inflamed, we have a thing called pleurisy, and it hurts to take a deep breath. The right lung base has three lobes, the superior, middle, and inferior. This is on the patient's right side. And the left only has two, the superior and inferior lobes. Now, each lobe contains air passages, alveoli, nerves, blood vessels, lymphatic vessels, which we'll talk about later, how that can affect the lungs, and also connective tissue. This is just the parts broken down. I'm not going to go through this. This is in your book, but I would highly recommend you review this to see what part, the description and the function of each one of the parts, which I just talked about. So how do we breathe? The breathing mechanism. So ventilation, or the act of breathing, is a movement of air in and out of the lungs. Simple. And that's composed of inspiration, taking in a big deep breath, which you hopefully heard me do, and expiration, which is blowing out, which I just did and maybe you heard. Inspiration, what happens is you have pressure all around your body from the atmosphere. I'll try to keep this as simple as I can for you. This is called atmospheric pressure. It's pressing down on every part of our body 24 hours a day, always. Now, this is what I explain to my respiratory students. I hope it makes sense to you. When you exhale, you have to create enough force inside of your lungs to blow out that will actually be higher than the atmospheric pressure, so you can exhale into the atmosphere. So you've got to overcome the atmospheric pressure with the pressure in your lungs to push out. When you breathe in, your diaphragm will actually pull down, expand your lungs, your rib cage will pull out. That will reduce the pressure in the lungs lower than the atmosphere. So therefore the air can travel from and this kind of goes back to concentration when you think about it. The atmospheric pressure is on the outside. We will lower the pressure in the lungs, so the air will move to the path of least resistance. That's going to be going down into the lungs, since the pressure will be lower there. Again, when we exhale, the diaphragm will move upward, the rib cage will come inwards, will push in on the lungs, creating pressure in the lungs to push the air out and above atmospheric pressure so it can actually exit your lungs. Now, due to the surface tension between the two layers of the pleura, the lungs follow the chest wall and expand. It's like when your chest wall moves out, your lungs will expand. When your chest wall moves inwards, you will exhale. Muscles involved in the expanding of the thorax cavity include, which I just mentioned, the diaphragm, which is a thick muscle that lines the lower part of the rib cage and actually separates out the thoracic cavity and the abdominal cavity. And then we have external intercostal muscles. They're going to be within the rib cage. They will contract and move to help move the ribs and the rib cage out and in to allow breathing. They'll probably mention this a little bit further, but I want to mention that inhalation, you actually have to contract those muscles and pull that rib cage open to pull those lungs and open them. That is what we call an active process. You have to pull and use muscles. When you exhale, all those muscles relax. The rib cage falls inward, the diaphragm falls upward, and you exhale. That is called passive, which means it doesn't take any effort to do that. And I tell my respiratory students, the last thing you will ever do is exhale, because you don't even have to be conscious to exhale. You do have to be conscious, or at least have brain function, to inhale. Now, the process of inspiration, the diaphragm is going to contract and move down. The external intercostal muscles will contract and move the ribs and sternum upward and outward, again, opening up that chest, so the pressure will fall inside the thoracic cavity, inside the lungs, so the air will actually roll right into the lungs from the atmosphere. The thoracic cavity enlarges with this process, and the lungs are going to expand. The intra-alveolar volume will increase, causing the pressure to decrease, like I said, or fall, about 2 millimeters of mercury. So pressure in the chest has to fall in order for air to come into the chest. It has to fall below the atmospheric pressure. As the lungs expand in size, which by this movement of muscle, surfactant in the lungs keeps the alveoli from sticking to each other, so they won't collapse when the internal air pressure is low. So surfactant keeps the alveoli from sticking to each other when internal air pressure is low. And at some point, I know in respiratory, surfactant is very important when we talk about neonates, because they don't have any. So the alveoli don't move and are not usable because they're all stuck together. We will actually give infants surfactant, shoot it into the lungs to make the alveoli more pliable, and they won't stick together. To take a deep breath, the diaphragm and external intercostal muscles contract more forcibly, plus the pectoral minor, sternocleidomastoid, and scalene muscles contract and pull the rib cage up and out. And as you can see in this process right here, intraalveolar pressure, atmospheric pressure, let me just say to you, unless told otherwise, the atmospheric pressure, the pressure on the outside of your body, is always 760 milligrams of mercury. Sometimes we'll refer to this as torr in the respiratory world. It's still pressure or mercury pressure. As you can see over here, I said that when the muscles contract and pull the chest open, you have to drop pressure in here in order for the air to rush in. And as I said in the previous slide, you have to drop it by at least 2 centimeters of water pressure. You see here we dropped it to 758, which allows the air to rush in because now the pressure is lower here. I sometimes tell my respiratory students, think of a waterfall. This is the waterfall. The air is coming to here and it's falling into the lungs. I know that seems kind of strange for what you might think, but it actually kind of falls in because the pressure is lower. If the pressure was not lower, air would not enter. It would just float around. It wouldn't come into your body. This is also a representation. Here's your external intercostal muscles that are going to move and contract and pull the lungs out and up. The sternocleidomastoid runs right up around your neck and the scalenes. This is the front part of your neck and the back part of your neck here. Your pectoris minor, which we'll talk about muscles later, is actually your breast muscle, which is out here. That's going to, so you probably ought to know which one of these muscles affect breathing and the diaphragm. And then that's going to allow the diaphragm to contract. Now, expiration, this is going to be the passive. The forces of expiration are due to the elastic recoil, or the lungs coming back down from being pulled apart, and the muscle tissues from the surface tension of the alveoli. And again, like it said, normal expiration is passive. The diaphragm and external intercostal muscles relax, the lungs recoil, and that therefore is going to decrease the volume in the thoracic cavity. But as it decreases that, it's making pressure. In respiratory, we talk about some gas laws that this represents, but I'm not going to go there right now. Just know that as your diaphragm moves and your rib cage comes inward, it's going to decrease the volume of the lungs, therefore increasing the pressure in your chest to exhale. And the intra-alveolar pressure will increase to about 1 above atmospheric pressure. So if atmospheric pressure, as we said here, is 760, we have to push out to about 761 in order to get the air out. Now, I'll mention this, we get into deep conversation in respiratory, that atmospheric pressure changes. 760 is at sea level, which we are not. The pressure is actually different here in West Virginia, and actually different as you get up into the mountains. And that does create some issues the higher you go, and that will be in the amount of oxygen that your alveoli actually have stored in them, but that's another lecture. But I wanted to mention that atmospheric pressure does change depending on what location you're at. 760 is sea level. Forced expiration is aided by internal intercostal muscles that compress the rib cage and abdominal wall muscles that compress the abdomen against the diaphragm. And you can all forcefully exhale, kind of, and we'll get into the lung volumes at some point because you'll be changing. There's actually a study of lung volumes, which respiratory does. And again, picture in your book, side cut. But keep in mind, everything, your diaphragm separates this abdominal cavity here. Any of these muscles will affect respiration if they are damaged. I will leave it at that. So respiratory air volumes and capacities. So the study of the air volumes within the lungs is called spirometry. There's a whole field of study that respiratory gets into regarding spirometry. And that just, we look at basically, there's a few more, but 4 distinct respiratory volumes. One inspiration followed by an expiration is called a respiratory cycle. That's just 1 in and 1 out. The amount of air that enters or leaves the lungs during one respiratory cycle is the tidal volume. So every time you take a breath, in and out, normal is about 500, and that can actually be divided by body weight, but about 500 milliliters. And if you look at a bottle of pop, like a 2-liter bottle, you can kind of get a guesstimate of how that volume would look if it was a physical thing you could see, how much that would be. During forced inspiration, the additional volume, or the inspiratory reserve volume, can be inhaled into the lungs. So if you're all sitting there, and I'm all hoping you are, if you take an extra deep breath and pull those lungs apart, take a big deep breath, that is called inspiratory reserve. That is above your tidal volume. That is reserve volume that's there if you need it, if you're running or get excited or whatever. But we call that an IRV, or inspiratory reserve. During maximal forced expiration, we call that ERV. Now, I'm sure you're all going to do this. Exhale down farther. So instead of just exhaling, go and blow out even farther. That is an expiratory reserve volume that can be obtained and used if you need it, if you're running. I guarantee if we all get excited or start running, we're going to go into our inspiratory reserve, which is above the tidal volume, and expiratory reserve, which is down below. And then below the expiratory reserve volume, there's a little bit of volume in the lung called a residual volume, we may get into that later, but we don't always access the residual volume, and that's give or take about 1,200 milliliters of air. Respiratory capacities are combinations of two or more volumes. So we have an inspiratory capacity. It's going to be your inspiratory, it is what it says, your inspiratory reserve volume plus your tidal volume is going to be how much capacity you have to inhale. So tidal volume is normal breath plus the as deep as you can go, and that would be approximately 3,000 milliliters. Functional residual capacity is your inspiratory above tidal volume plus your residual volume. And then we have the tidal volume, which is your tidal volume plus your inspiratory reserve and your expiratory reserve. And that's usually about 4,600 milliliters. And I'm hoping there should be a chart coming up that we can demonstrate this. This is very important when it comes to the world of respiratory and what is affected when we have lung diseases and lung injury or even chest deformalities with people. Tidal capacity plus residual volume is called total lung capacity. Vital capacity we measure quite often, though. That's your tidal volume, how much you can inhale above that, how much you can exhale below that. Then we have a little bit of anatomic dead space, and that's the air remaining in the bronchial tree that is not involved in gas exchange. So remember, from the nose clear down into the alveoli, we have this pathway of air to follow. Now, residual or anatomic dead space, I should say, you're going to have air left in your nasal passages, your bronchi, your trachea. It's still in there. It's not contributing to any kind of respiration, but it's there, and we call that dead space ventilation. Very good chart, and I hope you can see my pointer. This is going to be your tidal volume right through here, in and out as you do every minute of the day. When you take a great big deep breath, you're into your inspiratory reserve. When you exhale out as far as you can, that's called expiratory reserve. Okay. And when we get over to vital, and this right here, this long line, inspiratory reserve, this line below, expiratory reserve. The vital capacity is going to be how much you can access at any given time. That's all of your inspiration, what you're breathing normally, and then what you're going to exhale as much as you can. That's the capacity you have to create air movement. That's the way I think of that. Inspiratory capacity just takes that inspiratory volume plus tidal volume. Total lung capacity is total. If you know all the volumes, it's going to take in anything from inspiratory reserve to expiratory reserve to residual volume, which we will get into functional residual capacity later. And then there's just a chart from your book to describe what we just talked about. So let's talk about what controls your breathing. Normal breathing is rhythmic, involuntary, meaning you don't have to think about it. I would hope not. And even though the muscles are under voluntary control, you can take those extra deep breaths. The act of breathing is involuntary in itself. The respiratory areas are groups of neurons in the brain stem, and they comprise the respiratory areas, which control breathing by causing inspiration and expiration and by adjusting the rate and depth of breathing. When you go run, you don't have to think about taking deeper breaths. Your body responds to these changes by increasing lung volume, and fortunately, we don't have to think about that. The medullary rhythmic center includes two groups of neurons. Now, these neurons are the dorsal respiratory group and the ventral respiratory group. Now, the ventral respiratory group is responsible for the basic rhythmic breathing. The dorsal respiratory group stimulates the respiratory muscles, especially the diaphragm, and it may be involved in certain cardiopulmonary reflexes. Neurons and the pons of the brain form the pontine respiratory group, and they contribute to the rhythm of breathing by limiting inspiration. This is all done involuntary for the most part. If any of these groups are damaged, we could have areas that, or people or patients that may not be able to breathe, and we would have to breathe for them, like with spinal cord injuries. And again, in this picture, we're talking about the brain, and we're talking about the pons. You can see the brain stem is going to come out from the top of the brain here. The medulla oblongata is located. The ventral respiratory group is right below that, and then the dorsal group. And you can see the expiratory intercostal muscles and the diaphragm there. So remember that you have the ventral group responsible for the rhythm of breathing, the dorsal group of nerves that are actually going to affect the muscles and the diaphragm. And dorsal is here. So control of the breathing, rhythmic breathing, control of the muscles here. Basically, this is going to be your rate of how many times you breathe. This is going to be the depth and force of how much you breathe. And another diaphragm that basically breaks it up. I think it's pretty nice how they did this for you. And again, this is your rate, and that's going to be your dorsal group. And your ventral group basically does the rhythm of breathing, and this says it will affect the rate and also the depth and force. So, factors that affect breathing are going to be respiratory areas, or those nerves, chemicals, lung tissue stretching, your emotional state, all affect your breathing pattern. Chemosensitive areas, or central chemoreceptors, are associated with the respiratory center and are sensitive to changes in the blood concentration of carbon dioxide and hydrogen ions. And this is where we get into blood gases, arterial blood gases. This is also where we get into patients that are COPD, or what we call carbon dioxide retainers in their lungs. And that does affect the breathing center and the brain because the body gets used to having too much carbon dioxide. And that might be another lecture. In the chemosensitive areas, if either carbon dioxide or hydrogen ion concentrations rise, hydrogen ion is going to be your pH. The central chemoreceptors signal the respiratory center, and the breathing rate increases. So let's put it this way. If you start to get you're exercising, your pH, your acidity in your blood will go up. That will send a signal to your brain to breathe more or deeper. If carbon dioxide goes up, that means it's not being eliminated because we eliminate carbon dioxide when we exhale. If the carbon dioxide goes up from normal, then that is telling the brain that you need to breathe more because I've got too much carbon dioxide in my body. The more CO2 or carbon dioxide is exhaled, blood and cerebral spinal fluid levels fall, and breathing then returns to normal. And that's a whole other topic too that we can talk about when it comes to pressures in the brain with cerebral spinal fluid and CO2 and their correlation. The breathing rate will increase if carbon dioxide or oxygen or hydrogen ion concentration decrease to build up CO2 levels to normal. So the breathing rate will decrease if CO2 or the hydrogen concentration decrease. So if you're exercising and your acid level goes up in your body, respirations go up. Once you sit down and relax, then your breathing is going to come down because the acid is going to be lowered in your body. If CO2 goes up because you're not breathing very well, you're going to breathe faster to get rid of it. As the CO2 is eliminated and comes back to normal, then your breathing will actually slow down because it knows it doesn't have to breathe as fast anymore. The peripheral chemoreceptors in the carotid bodies and aortic bodies sense changes in blood oxygen concentration. They transmit impulses to the respiratory center, and breathing rate and tidal volume increase. So keep in mind, when we go back, breathing is regulated by the amount of your body's pH, or how acidic you are, by the amount of CO2 in your bloodstream, and also by how much oxygen you have in your body. Blood oxygen levels must be very low to stimulate these receptors. These are the peripheral ones in the carotid bodies. So they're located in the carotid areas of the circulatory system and in the aortic notch, which when we talk about circulation, that's going to be right coming off the heart. It's where these chemoreceptors, or these receptors, are going to be located. So when your blood oxygen falls very low, it's going it's going to stimulate these receptors to breathe more. Oxygen plays a very minor role in respiratory control, however. Carbon dioxide in normal people, average healthy people, is going to be the major thing that regulates your breathing. And it's going to stimulate those receptor sites. So oxygen is going to be the last thing that actually makes you breathe faster. It's going to be, if you stopped breathing right now, it wouldn't be the lack of oxygen that made you breathe faster. It would be the fact that carbon dioxide is not being eliminated and is increasing, and that would cause your body to breathe faster or attempt to breathe. Again, we're talking about the aortic bodies and the chemoreceptors. Here's the aorta where some of those receptors, this is your oxygen receptors right here. The carotid bodies, now carotid arteries are up around your neck area where the other receptors are. We have such a thing called an inflation reflex, triggered by stretch receptors of the visceral pleura and bronchioles and alveoli. And this helps to prevent overinflation of the lungs during forceful breathing. You can't blow up your own lungs because of the inflation reflex. You can only take a breath so deep and then you can't anymore because your body will stop you. Now, emotions can alter breathing patterns as well as conscious control. If you get nervous, sad, anxiety, that's all going to affect your breathing patterns. Now, hyper meaning more ventilation, lowers the amount of carbon dioxide in the blood. So, if you're hyperventilating, people with anxiety, I always give the example of the 16-year-old girl that fights with her boyfriend and comes to the ER. They're breathing fast. So they're getting rid of a lot of carbon dioxide unnecessarily in their body. Now, let me go back to hyperventilation. What happens is when you eliminate a lot of carbon dioxide that doesn't need to be eliminated, that will actually vasoconstrict, causing vessels in your body to get smaller. That will actually reduce blood flow to the brain. And it also causes tingling in the hands and fingers, can also cause chest pain. So if you have a patient that presents to you, they look like they're anxious, they're having tingling in the fingers, chest pain, headaches, dizziness, you might want to have them slow their breathing down because it's probably just hyperventilation. If they do it long enough, they're going to decrease perfusion to the brain. They'll eventually pass out, and then they'll come back to normal. They more than likely won't die. They'll just pass out from lack of blood flow, and then their breathing will return to normal because they won't have anything to be excited about anymore. Let's get down to the alveolar gas exchange. The alveoli are the only sites of gas exchange between the atmosphere and the blood. This is where it all occurs. Now, the alveoli are these tiny little air sacs. They kind of look like grapes. I showed you in a picture previously. They're clustered at the distal or far ends of the alveolar ducts. Again, here's your alveoli, your bronchioles, smooth muscle that attaches around these. Now, this can also be associated with bronchospasm because there's muscle here. And again, this is going to be where all the oxygen exchange and CO2 exchange occurs. Now, the respiratory membrane consists of the simple squamous epithelial cells of the alveolus and endothelial cells, simple squamous epithelium of the capillary, and the two fused basement membranes of these layers. Gas exchange occurs across the respiratory membrane. So the whole membrane is where the gas exchange occurs. And here we have deoxygenated blood coming into the alveoli. And the CO2, it's going to be CO2 rich. That's going to be dumped into the alveoli. Oxygen is going to be dumped in. And sometimes I consider this like a train car carrying little train cars. I don't know how else to say it. And it comes in with a bunch of stuff it doesn't need, gets rid of it, and picks up the good stuff. As the blood becomes oxygenated, more and more oxygenated, more CO2 is eliminated into the alveoli. The blood becomes more red, and that indicates that it is oxygenated. The CO2 will thus be eliminated when you exhale. and the oxygen will be brought in from the atmosphere. So that's basically how this works around the alveoli. The alveoli do have macrophages in them and surfactant secreting cells that can be damaged. And if that happens, then you have remodeling or stiffening of the alveoli. Hopefully, this can occur with some chronic disease or pneumonias if these are eliminated or decreased. This is the fluid with the surfactant that this produces, and this keeps the alveoli from collapsing and also from sticking together, which would be part of collapsing. The diffusion across the respiratory membrane, gas diffuses across from areas of higher pressure to areas of lower pressure. And we talked about this way back in like lecture 1 or 2. In the mixture of gases, each gas accounts for a portion of the total pressure, or what we call in respiratory the partial pressure. The amount of pressure each gas exerts is equal to its partial pressure. When the partial pressure of oxygen is higher in the alveoli and the alveolar air than it is into the capillary blood, oxygen will diffuse into the blood. Let's just say that one more time. When the pressure of oxygen is higher in the little alveolar sacs, then it's going to move from higher concentration to lower, as I said up here. So if you have a lot of oxygen in the alveoli, it's going to move out into the capillary blood. And that's what's occurring here. The pressure of oxygen is higher here. It moves into the capillary blood, and we would hope it would, because that is going to be circulated to the rest of your cells and organs in your body. The pressure of CO2 is higher in the venous blood, so therefore it's going to go from higher concentration to lower concentration in the alveoli to allow it to be expelled. When the partial pressure, I think I just said that, when the partial pressure of oxygen is higher in the alveolar air than it is in the capillary blood, oxygen will diffuse into the bloodstream. And that's what I was representing to you just now. Diffusion across the respiratory membrane, when the partial pressure of carbon dioxide is greater in the blood, which I just indicated to you, than in the alveolar air, then the carbon dioxide will move into the alveolar space because it's lower concentration, and then you will exhale that. So I'm just kind of repeating myself. A number of factors favor increased diffusion. If you have more surface area of the alveoli, then you have more area for this diffusion to occur. So the diffusion will have a bigger playing field to play on. So it'll diffuse faster. The shorter the distance, so if there's no injury or remodeling or damage to the alveoli, the distance between the capillary bed and the membrane to the alveoli is going to be short. You're going to have fast exchange, which is a good thing. The greater the solubility of the gases is going to make them diffuse faster. And a steeper partial pressure gradient is going to make them diffuse faster. Now, people that have chronic lung disease, COPD, people that smoke, you are thickening that membrane around the alveoli, and that is going to cause diffusion from the blood system and the alveoli to slow. So you're not going to pick up oxygen as well, and that leads, you're not going to get rid of CO2 as well either. So that's going to lead to long-term problems, and why some people end up on oxygen, supplemental oxygen, as their situation deteriorates from the disease process. Again, we're talking about partial pressures. Looks like this is the capillary bed here. This is going to be the membrane of the alveolar wall. And remember, partial, the higher the concentration, it's going to move from higher concentration, like CO2 right here, 45, moving into the alveoli, which is only 40. So you can exhale it. And again, we're just showing again, oxygen in the alveoli, which there's a calculation we do in respiratory to calculate this. Alveolar oxygen is at least 100, and that is going to be much higher than what's in the capillary blood coming in. That's deoxygenated, so it's going to automatically move in, and that is a gas law in itself. The thickening of this membrane will cause diffusion to be impaired. Gas transport. Gases are transported in association with molecules in the blood or dissolved in plasma. So gas transport occurs in two different ways. It's either going to be in the molecules on the blood or in the hemoglobin in particularly, or we're going to have a little bit of the gases dissolved in the plasma. So if you've ever been to a doctor and saw your blood and they've ever spun it down, the blood will actually separate into the whole red blood, and then you will have this plasma, which is yellowish. And each one of those has carrying capacity for molecules of the blood. I can tell you this, plasma doesn't have as much as the actual red blood cells. Red blood cells does the heavy work, especially when it comes to oxygen transportation. Over 98% of your oxygen is carried in the blood bound to hemoglobin that is located on the red blood cells. And when you have hemoglobin that has oxygen, we call that oxyhemoglobin. So you kind of put the two words together. Oxyhemoglobin is oxygen on hemoglobin. The remaining 2% is carried dissolved in plasma. So not a whole lot. So the majority of your oxygen is transported as oxyhemoglobin attached, which is the oxygen attached to the hemoglobin. Now, diffusion from the blood into the tissues. Oxyhemoglobin is very unstable. Oxygenated hemoglobin is unstable in areas where the concentration of oxygen is lower because, remember, it moves from higher concentration to lower concentration, that basic little gas law we talked about. So if you have all this oxygen on your hemoglobin and it's floating around to an area that is low, it's going to want to dump off or release the oxygen to the area of low concentration. It gives up its oxygen molecules in those areas, which in most cases that's what we want because we need to deliver oxygen to the cellular level so the cells can have internal respiration inside of the cells, which we talked about in an earlier lecture. More oxygen is released as the blood concentration of carbon dioxide increases, as the blood becomes more acidic, and as the blood temperature increases. So more oxygen is going to be released from the hemoglobin if carbon dioxide increases. This is in the blood system. As the blood becomes more acidic, and as the blood temperature increases. Now, I'm not sure we're going to talk about it today or in this class, but when respiratory, there's a whole calculation we can do for changes. Let me add to this. That's called the oxygen dissociation curve, but probably doesn't mean a whole lot to you. But let me tell you this: that if you run a fever, you will automatically have less oxygen available in your body because what's happening is the oxygen is being released from the hemoglobin too soon, and it's going to affect your overall blood content of oxygen. As your fever comes down, your oxygen will be transported along as it should, and your oxygen level would actually come up. Most people don't realize that. You would have to have one of those pulse oximeters on your finger to actually see how that works. But trust me, your oxygen does go down when you have a fever. A deficiency in oxygen reaching the tissues is called hypoxia. So flat out, oxygen doesn't get to the tissues, hypoxia, and it has a wide variety of causes. Let me get the right slide going here. So anyway, we're talking about diffusion again. These are the cells out here, and oxygen will be in low concentration here. It's going to be in high concentration here. That's what allows it to diffuse into the cells. The cells are producing CO2. CO2 is coming back in to be eliminated from the body. It's all a matter of diffusion, going from higher concentration to lower, whether it be in the alveoli or in the cells. Carbon dioxide may be transported dissolved in your blood plasma. So about 7% of the carbon dioxide coming out of your cells, that is basically a waste product, is going to be carried in your blood plasma. Carbon dioxide forms a weak bond with the globin part of the hemoglobin to form carboniohemoglobin, which is about 23%. Sorry for butchering the word. Most carbon dioxide is transported in the form of bicarbonate, and about 70%. So CO2 plus water equals H2CO3, which is carbonic acid. There's a name to this equation. I always call it, I think it's the Henderson-Hasselbalch equation, is really what this is representing. So CO2 and water, and we all have water. When you exhale, you can follow a mirror. If you breathe against the mirror, it gets wet. That proves that you have water coming out of your body. CO2 and water form carbonic acid, which is then broken down into hydrogen ion and bicarbonate. And this equation actually goes back and forth. It's very unstable. It can go either direction at any time. The bicarbonate ion diffuses out of the red blood cells and enters the plasma. And the reaction is aided by carbonic anhydrase. Carbon dioxide enters the blood from the tissues. Carbon dioxide is released easily in the areas of low CO2 pressure. Again, because you don't have a lot of CO2 in the lungs, CO2 comes into the lungs through the bloodstream, and that's what allows it to move into the alveoli to be exhaled. The carbonominohemoglobin also releases its carbon dioxide, which diffuses out of the blood into the alveolar air. So carbon dioxide is transported 2 different ways back to your lungs, basically. And this is just showing you cellular respiration, creating CO2, and how you're going to have CO2, about 70% of it, or 7% of it, 7% of it is dissolved in plasma, and the other is going to be brought back as 23%. Carboniohemoglobin. And it's going to be back and eliminated through breathing. Another representation about CO2. This is the alveoli. CO2 is higher concentration here, lower concentration, it moves out. So it's just showing you the movement. Oxygen would be in higher concentration here, lower here, so the oxygen would move into here. Again, something to kind of be familiar with, which is basically the amount of oxyhemoglobin that you have. We talk about that more in respiratory. I can tell you that this comes into play when we have carbon monoxide poisoning, because the carbon monoxide, which people, for lack of better words, suck on the tailpipe or try to kill themselves by putting gas fumes into their car, it's going to take the place of oxygen on the oxyhemoglobin. It will no longer be oxyhemoglobin. It will be carbonohemoglobin, I believe it's called, and you will be hypoxic, and you eventually will die because you have no oxygen attached to your hemoglobin, because the carbon monoxide will take the place of it. The treatment for that, let me say, if you have anybody with carbon monoxide poisoning, it's a tasteless, colorless gas. Your patient will come into the ER usually kind of cherry red in color, maybe unconscious. If you suspect this, it could be from gas stoves even, where there's just no flame and only gas entering the home. It's to put them on as much oxygen, 100% oxygen if possible, to try to drive the carbon monoxide off the hemoglobin and allow the oxygen to bind to it. That is it. You made it. I hope you enjoyed the lecture. Please, anytime, if you have any questions, let me know. This is kind of my expertise of respiratory. I'm currently out of town, and I will have at least one more lecture for you to entertain you while I'm gone. Y'all have a wonderful day, and we will talk later.